Good morning, everyone. I will be sharing our experience of paravalvular leak closure using Amplatzer vascular plug free. A PVL device closure is increasing perform nowadays with good outcomes. However, the size, shape, and the number of the leaks are extremely variable, and it requires multiple sessions and multiple devices. And most of the devices used are used off-label. Owing to its oblong shape, the AVP3 device is now considered to be one of the most favorable device for paravalvular leak. So we did a retrospective review of all cases of paravalvular leak that was done in our institution in last 8 years using AVP3. We included those cases where other devices were also used along with AVP3. We analyzed the technical feasibility, complications during and in post-op period. The median follow-up of our study group was 24 months. Among the 79 cases we did, AVP3 was used in 16 cases, and most of them were adult males, and aortic and mitral paravalvular leaks were equal in number. Two-thirds has mechanical prosthetic valves, and most of them were in NYHA class 3 or 4. About half of the cases had more than one cardiac surgery in the past. Among the 16 cases, 18 devices were used, where 2 devices were used in 2 mitral paravalvular leaks. The most commonly used device was 12x5, and for all the aortic paravalvular leaks, the arterial access was used for retrograde deployment of the device using the appropriate size sheath. And for mitral, we took transeptal access for all the patients, and along with that, we used to use either apical access or arterial access for crossing the leak and forming a wheel load. Most of them were deployed through transeptal access, and only one was through the apical sheath. There was failure to implant the device in one 10x3 device due to difficulty in advancing through the sheath. There was no device embolization. There was no interference in the disc mechanical valve disc mobility during the procedure, and there was technical success in 100% of cases. There was no procedural mortality, and there was complication of hemopericardium in 1 and hemothorax in 2 that were related to apical punctures, which were used in 3 cases. During the follow-up, there was significant improvement in the severity of leak, and only 2 cases had persistent mild to moderate leak, and functional class, there was significant improvement in the functional class. The 2 patients who had residual leak were addressed again with the redo procedure and implementation of further devices. The only drawback is we included other cases, the 12 cases where other devices also were used along with AVP3, which actually hinders the results. However, the technical feasibility can be assessed by this study. By this, we can conclude that AVP3 for paravalvular leak has good technical success with no significant complications and good short and intermediate term outcomes. Thank you.